Thank you very much. I would actually see that as a success on the research side and the problem in the take-up. But that is actually an important part of where I think this discussion ought to be going, which is to demonstrate and to discuss issues around the value that research can bring to organizations. I think certainly from the researcher side, being in an organization makes the research more valuable. But I think what we're also hearing is that the speed, the ability to answer important questions quickly is a challenge for the researcher side, but it's also the way to provide more value to the organization. So with that, let me open this up for discussion. We've got about 15 minutes, and I'd like to hear questions. Please use the microphone when you... Yes.
Jim Rohack from Scott and White Central, or Baylor Scott and White Central.
And thank you for identifying yourself.
Sure. So the question all four folks presented very good information that seemed to indicate that there was a tension between academic enterprise that's supposed to create new knowledge, operations for the delivery of health science that you learn, and how you pay for it. So can there be a national solution, or is all healthcare local and everything has to be done in each community to make all this stuff work?
Members of the panel?
I'll take a stab at that. So I think, so you identified a couple tensions. You know, the tension between reimbursement or paying for stuff and doing stuff. I acknowledge that as a real problem that we need to scream about, frankly. The tension between academic rigor and operational contingencies, I think I don't think that's a real one. In our research group, the people that we're sort of developing, the way we're developing, we feel like we need to be able to do both and to be able to move back and forth and to say, this is a grant that we have from NIH and this is going to have rigor that's going to pass muster at the best journal we can possibly publish in. At the same time, we make ourselves available to the organization and do evaluations of projects that maybe are more pragmatic, may never pass muster at a journal, or if they do, it will be one of the, journal maybe perhaps of lesser repute, if you will. So I don't see a tension there at all. I think that you have to be able to move back and forth between these two things very easily. And I think that most of the panelists here are in a position where they are doing both academic research and serving an enterprise. And I think it's a skill set we need to demand of ourselves.
If there's a tension, I would call it a positive tension. I think that in our organization, we don't necessarily believe that everything has to be invented in our place for sure. There are processes in place in the enterprise to actually do evidence scans and understand what's the best evidence. And in the value-based insurance design, we were asked, what do we know about the potential value of this design, and what's the evidence to date to suggest that this would be a worthwhile proposition, both from a quality as well as a business standpoint. There were clear gaps from the perspective of the researchers, and it was actually precisely those gaps that led to this effort to say, okay, well, let's try it out and let's see if we can extend the model a little bit. But that tension is a good tension. I think that the communication back to the research group that doesn't have those necessarily the same breadth of knowledge of the enterprise needs sometimes can, I think, be a very edifying one that brings forth a stronger institute.
I think there is a tension. I think it has to do with some of the comments made about both timeline and time to results and pragmatic positions that people running enterprises find themselves in versus, developing ideal solutions. So it's fair to acknowledge the tension. I also don't think there are good designs for how to do end-to-end research. So that really puts this into a one-off kind of category. So you heard examples, but how sustainable are they? What is the rate of innovation? How rapidly do new products get developed? How well do we upgrade our outputs? That's really the important question to answer. If we answer that question, we can design the right design. But we are unfortunately designing at a micro level, at a small context level, and then trying to replicate it many, many times. And that doesn't get us to answers at scale. So I do believe there is tension. I believe it's the right kind of tension. But I'm not convinced that our approach to it addresses end-to-end research. Ask the question, what will it take to be a continuous learning system? There are designs, but they've not actually been replicated sufficiently to say we know how this looks and let's scale it up. So I think that's where we need to go.
And I think there is a strong tension, and I'll give some examples. And I think that's why it's important to have good examples where things synergize well, where the tensions are resolved, to be able to look at areas and questions where it's much harder to bring both the thought leaders and the academics together with health system desires to put that as a priority. And the example that I'll give is quality improvement. And if you look at the hospitals across the United States, there's a reason why hospitals use all sorts of devices and all sorts of products. And there is not uniformity, and it's because we don't always know the answer. And because health systems who have problems and hospitals who have problems want answers right now. They want to bring their rates down. They want to fix whatever problem has been identified. And when you choose to engage in a trial, one of the greatest things that we deal with in both the Reduce MRSA trial and the one that we're doing now is to hold back other types of interventions that could impact the trial. And that's very hard. And the tension's there for a hospital where quality improvement is naturally looking for anything that they feel in their gut is a reasonable thing to try to address a problem, flies directly in the face of research when you need to control so that you have a definitive answer for one particular intervention. And I think that's why the speed and the strength of health systems to have large numbers in a fast amount of time to answer a question, because you can only stave them off so long when other things are happening that they want to change. So I think that's very real, and I think the dissemination is very real. HCA wanted to roll it out the minute we knew. We knew the answer 9 months after the trial. We held it for an abstract, we held it for publication, and the minute it came out, that week, they rolled out to their entire health system. But they waited because we asked them to wait. So I think there is a good tension that is real that needs to be addressed, and we can move forward to try to address those things together.
One other area of tension, I believe, is what requires a randomized trial and what requires pragmatic trials. And I don't think that problem is resolved yet. So if everything, the only truth can come from a randomized trial, that is a challenge as well. And that's an unstated conversation, I think, that causes the tension.
And let me just jump in also, because I think this academic system may or may not change rapidly enough. But I think to some extent, as researchers become embedded within delivery systems, have an alternative funding source that's better than a 5% pay line at the NIH, allows them to do research that has an impact right away in New England Journal is pretty high quality. But I think also we are going to be able to figure out ways of assessing the quality of research by the take-up of it. There are lots of other ways other than doing the standard peer review process. So I think that's going to be changing over time. I think PCORI funding and other things are really moving in that direction. Yes, sir.
David Ballard with Baylor Scott and White Health. I have a question for David or maybe for Eric Larson. So your 95% external funding for the Research Institute, one level is really impressive. But another thought I have, though, is that we need people who have a foot in one camp, healthcare delivery research, who also have a foot in quality improvement operations. And there's no way that you can adequately address the quality improvement operations aspects of implementing the evidence from health services research if you have people living in an environment where 95% of their funding comes from outside the organization. So could you comment on how you deal with that tension within group health?
Yeah, it's a great question. So I don't get 95% of my funding from external fund sources, and I think the key is how you distribute those funds. So in part that I think the model that has evolved, and I can't say it was totally intentional, but it certainly has evolved, is one in which we have multiple clinician investigators. And Eric, I think, has made it a key priority to actually bring more clinician investigators into our institute, and partly to build those bridges, both clinically as a means to develop for them to be liaisons to those that are taking care of those patients, but also operationally. And so some of those, we have multiple people who actually serve in operational roles with varying proportions of FTE that are supported by the institution. So my salary, obviously is, I'm actually only spending approximately 30 to 40% of my time in the research enterprise, sometimes even some months less than that. And there are a couple of us that are like that. And those people actually serve as key bridges and ambassadors, liaisons, interpreters, vet, and help to vet and that sort of thing. And of course, in Eric's role as reporting to the CEO, as vice president is really key in order for him to be able to maintain that direct tie for the research institute. So the 95% is a reflection of leverage. It's, but certainly in the terms of how those dollars get distributed, they're not distributed evenly. And so you're absolutely correct. I'm deeply involved in the guideline work, and both for care management and as well as all of our clinical guidelines. And as is Rob Reed has been in the past, and Paolo Lozano in our group, there are a number of people who have those key ties, I think, that then have a responsibility to actually work with the entire research group. There are also many investigators, by the way, who, as a result of that, have developed independent relationships, very robust ones, that are sustainable and keep going on, and they understand that part of their role, much in the way we see service, as part of our role, and that this is part of the service, it's part of the service of the institution to be involved with those people.
Yes, sir. So OSTP, the Office of Science and Technology Policy, is working to rewrite the common rule. And given that a lot of the delay in getting this work done is the unclear boundaries between operational research and clinical research, and at the back end probably depends where you publish it. But what would panel members like to see in terms of the front-end consent process for doing operational research that would segregate it away from doing what would be considered a more, investigative process with patients?
I think probably everybody up here would agree that IRB issues are an impediment to doing this kind of work, and depending on where you are, it's anywhere from a minor to a major annoyance. Clearly there have to be some changes made. I think, for me personally, I think that the idea that there's some ethical imperative in improving this system, right? And to the extent that we impede the improvement in this system, we're doing something that's probably unethical. And I think systems need to recognize that when there needs to be a very quick, expedited process for demonstrating that things are of no or little risk to individual patients, and that the risk in not doing it is substantial, we need to move ahead. So yeah, there needs to be a real lifting of this cloud over us that's imposed by the IRBs.
Hi, Jonathan Tobin, Clinical Directors Network and Rockefeller University. I wonder if you could comment on the downstream uptake and implementation. You have data from the duration of the trials that you've described, particularly the work on hypertension control, on reducing MRSA. But I'm curious whether we can look at some of the organizational variables that may facilitate or inhibit the uptake, scale up, and sustainability, and how that part of dissemination and implementation research is built into the projects that you've described.
So for the reduced MRSA trial, because we were trying to use regular infrastructure and the usual way in which education is done, when this was rolled out across the other HCA hospitals, they were able to take the computer-based training module, for example, and the protocols and just strip the research lingo out of certain pieces of it and really roll out almost identically the same toolkit that was created for the trial. And I think that that wasn't by chance. That was because when most of us who were part of the trial wear the hat of being a quality improvement or hospital epidemiologist, and so we knew what would fly if we tried to do it in our own institution. And I think those questions have to be done at the outset instead of as an afterthought on how this could be well disseminated.
Yeah, so this is Patrick Conway from Centers for Medicare and Medicaid Services. If we accept the goal as a continuous learning health system, high quality, high value through integration of care and research, and then we started to touch on this. We have a few examples here. I've been to lots of meetings, as is everybody in this room, with a few great examples. How do we accelerate the pace of change? So how do you make this the common as opposed to the uncommon? And what are the key levers?
Patrick, I think, looking at funding by people that pay for healthcare, that pay for innovation is important. Currently, our streams of both revenue and incentives are dissociated, so that, if you look at other industries, and certainly at Cincinnati, we have a lot of P&G people on our board, they don't see those as two separate activities. They see what they would call the upgrade of the product as a fundamental part of the delivery process. So it would be important for people paying for healthcare to require continuous innovation in healthcare rather than a 20-year look back to say, now, what can you do to apply the things that you should have applied, 20 years ago, like hospital-acquired conditions. So what does that look like? What is the big lever is the question, and why would payment not include, as you saw examples here, a reduction in cost and an improvement in outcome and a requirement for that?
I think also that we've not historically been very clear on what the business case is for the research that we do. We don't lay out exactly what the proposed business case is. And I think that the process that we're describing is leading us in that direction. It's forcing us actually to be more explicit. And I'm not just talking about the financial business case. I'm talking about the broader set of business cases, economic, social, and clearly the intangibles that relate to that. But rarely do you see that laid out very clearly. And certainly funding agencies often don't ask you for that. And so by the time you finish the study, the business case is unclear. And it forces people to scratch their heads a little bit and understand whether or not this really is something that makes sense from a business standpoint in terms of dissemination.
Could you turn your mic on, please?
Sorry. There we go. Tricia Smith with the Alliance of Community Health Plans. Dr. Kodagal, you referenced the fact that we needed better end-to-end design. And went on to say that we try to do projects at one level and then apply them or scale them in a much larger universe. Could you speak to that a little bit more? What do you mean by broader, better end-to-end design and that scalability issue?
So we're testing this theory, so it is a theory. If we look at networks as an engine for building end-to-end research, what we have there is a large volume of patients. What we have there are providers and patients coming together to say, what are the important questions? We have data that's reliably collected on outcomes and key processes. So we have what we would call, a practice in which you could detect signals much faster than where there's such wide variation that there's so much noise in the system that picking up that something is significantly different is hard. And we've seen this replicated every time we improve the practice, that we can pick up signals better. Now, into that practice, if you build your team that includes basic researchers and clinicians and patients, then you are building a system that could answer important questions. So the example I gave, for example, in Cincinnati, in the IBD, which I think is part of what Improved Care Now is trying to do at scale, Understanding what is our true remission rate and what is our true steroid-free remission rate is important. Once we get that, then having patients and providers say what is important to them is important. At Cincinnati, we've said steroid-free remission rate is more important than remission rate. Now we can ask the question for the 100 kids who are not in steroid-free remission rate, what's going on here? Is it adherence? Is it self-management? Is it that their biomarkers are different? Is it something that pre-directs them to have these failure rates? Then we've got a clinical investigator, a clinician, an improvements person, a nurse, data that enables us to run our experiments. If we did that at scale, I believe we would answer questions much faster. We're trying to answer that question, what would get you to be best in class? And where are the gaps? And what we find in our own analysis of our teams is that sometimes they're not applying the evidence reliably. Sometimes they're not applying it reliably, sustainably. So maybe they did it really well for 6 months, 8 months, 10 months, and then the team changed and something fell off. But sometimes their researchers are not sitting at the table with the clinicians and saying, hey, this is really interesting. Here's a question I've been thinking about in the laboratory. How do I answer that? And how would we build that at scale? So, we have a network of 80 practices funded by 80 hospitals funded by CMMI for safety. But we're not doing what Susan's doing, which is to answer, embedded in it, after we've reduced infections to a pretty significant rate, a randomized trial that says, hey, what's the important question that we don't know the answer to? If we could do that sufficiently, I think we would move faster.
Good morning. Audrius Polakaitis from the University of Illinois Health System. At that organization, I serve in the role of Chief Information Officer. And this meeting is very interesting because it's the first opportunity that I've had to think about this very topic that we're all discussing. When I think about my daily responsibilities, I would say that my primary job is to keep the trains running every day and make sure none of the trains stop and all the trains are on time. And yet I realize that in my role, this role would be one of the key players in facilitating this integration. And yet last night in a cab ride, when I was asked the question whether my schedule will allow for time to participate in these types of activities, the frank answer is no, not really, because it is a full-time job to keep the trains running, unfortunately. So one of the challenges that strikes me as I was listening to the panelists is this whole notion of how do we fund people in this cross-pollination method so that they do have feet in both sides. Again, given that we are a safety net organization as well, the comments from Denver Health were very interesting to listen to and some of those challenges. But right now we seem to be structured organizationally to keep these things separate. Perhaps an obvious conclusion to the rest of you, to me an insight. Thanks.
Well, I'll make a comment because that question begs the second meeting in our session. How do we have the executive leadership of our organizations realize that you need the time to work on that? And with that, I'll sort of answer your question, but also thank everybody on the panel. Joe and I just whispered to each other, this is a fabulous start for our session. And so thank you all for your participation.